Minister, since you've had such a tremendous experience, you were the minister, you were in the healthcare system always. Now, how, with these different evolutions, you've seen the difference between patients. Patients are trying to be more involved in the healthcare system. How can the patients be an actor of their own health? Yes, I understand. Well, the question is, so since you have been working, yes, in healthcare, so how have I seen the patient's situation evolve? Yes. I have seen the situation evolve for patients. And we have tried, in fact, we had this group at the Ministry of Health, and we wanted to allow other openings, evolution of patients, and also systems that were involved with patients. This is this law of the sick persons, 2002, and we can try and look at the outcomes. And maybe it wouldn't just be fantastic, but in fact, I do think there has been a change. Today, we are interested in not only the system itself, but also the doctors in the system, but also we're interested in the patients. I always say the word patient is something can be also debated, but the patient, their passivity for many, many years is something we talk about. Now, it's really a question of terminology that we use, but let's call them patients. And so the patient or the user of the system, they were the inert person, passive. We were interested in their disease, illness, but not so much the patient. Well, let's not generalize, though. But still, we're more, sometimes it depended on if the dialogue was easy or not. But legally speaking, we had to have a certain number of rights that were proposed and that they accepted. Now, it's first of all, foremost to say that this period, this was 20 years ago, 20 years ago when this law was passed, so let's say been 25 years ago, there was a lot of agitation. That's the least we can say. In fact, there was AIDS, etc. There were other different contaminated blood issues. So we're questioning all these questions, and also questioning the insufficient knowledge of doctors. And in fact, with AIDS, we had to learn a lot. In fact, things are different, the way things happen. But then, because AIDS was new, but then you had this period which was very favorable for us to think about with different groups. We asked and wanted to constitute and do work within the Ministry of Health. And it was very long and difficult. In fact, it took 2 years. And what was the result? In complement of what we call these different general states of health forums, and there was an understanding. We had 1,000 meetings that were meetings which were very specific, because usually, in fact, maybe we'll be doing this for the end-of-life issues. These are what we call citizen groups today. So this sounds Republican, but doesn't change using different terminology. We are used to asking the prefect to constitute these groups, to give the resources, so to just let the demands come from everywhere. You have a sickness person, a director of a hospital, etc. So these different demands were coming from all these different sources. And so we were supplying to the ministry and also providing to the minister's cabinet. We had a possibility of asking questions in this forum, and things went well because this law of the sick in 2002, and in fact, we had Philippe Lemoureux, who's with us. Where are you, Philippe? He's over there, Philippe. I could not see you. Okay, don't hesitate to interrupt me, Philippe. So we had the feeling that this law, which had not yet been drafted, it would be shocking doctors. And then we thought the doctors would have a reaction. What are you getting involved in? The relationship between the doctors and the and the sick is done with us, and I'm the doctor. And so the hostility was emerging. And in the different États généraux de la santé, these general state meetings, we didn't have that feeling. So, in fact, the sick persons had much more knowledge than we thought, and the relationship was going quite well. And the questions were very interesting. And the responses to these questions being raised was interesting. So we were reassured and comforted. So to ask, however, we're asking thinking of asking the opinions of the patients concerning this situation. That was something new to ask their opinion. It is actually stipulated in the law. There's always this legal terminology, which is very interesting the way they put things. And basically, the doctors cannot decide alone. You don't start that way. But the patient is interested in their life, in their body, and their diagnosis, which comes from the different checkups, examinations, and the decisions, their treatment decisions must be taken in between the patient and the doctors. So there you had this requirement was there, and we don't make decisions without explaining, and that already, of course, was being done in a lot. It was not very original, but here you have this rigidity. You have to explain. The decision is taken together, and then we apply it together. So there are many different chapters that stipulate that. They talk about the responsibility of the patient, the responsibility of the doctor, the collective responsibility, etc. All of this went quite smoothly. However, there also were different incidents, not in fine-tuning the law. However, there were some incidents that we're calling treatment issues. And what we know less, in fact, you had these different exceptional situations. Whenever there was malpractice, as usual, and at this time it was the director of the hospital that was responsible, not the doctor, then it could be the doctor. But above all, you had this without any error part. At the end of the healthcare insurance, and it was necessary to codify what is an error, what is malpractice. This is why we created this situation where, first of all, we started this out in the province. We had analysis of the risk, the consequences of the risk, and locally, first of all, and then we presented this dossier at the regional level. They discussed it, and they proposed a repair. We could also, in fact, there was a possibility of protesting as well, appealing. However, if this regional committee was saying, they would be actually proposing to the sick person some repair. And so otherwise we go all the way to Paris, where all the most difficult dossiers were regrouped. Now, this is working well. We have this organization for this purpose. Maybe you have some figures to quantify this? Well, in any case, he was my director, the deputy director of my cabinet. So, Didier Tabuteau was your director. Yes, the deputy. Hello, sir. Hello, there he is. These are the ones who actually drafted the law that you signed. You just signed it? Okay, seriously speaking. Now, we had cases like that. We had, for example, I'm not going to tell you everything because it would take too much time, and there's so many things I could share with you. It would take time because this whole, as you can see, this really shows us that in fact, this shows us there was no oppression. However, for example, the model of the knowledge of the patient was a medical report, and then there were the medical records. So if you all know the medical records, you're incapable of reading them because they're you cannot read them, illegible, and so, but they're very difficult to read unless you're familiar with this. Now, First of all, this required to have the medical record. Each patient can take his dossier, his files. Not many of them do this. Well, sometimes when we ask for them, we don't get them. When we, well, in fact, unfortunately, it's hard for me to understand because of your voice. I'm very sorry, but okay, no. There were sometimes I do have some neurons that are present here despite my voice issue. So we did advance. The work that was done progressed. And what happened is that the Internet, in fact, made the situation if the patient did not have the information from the healthcare professionals, then he would search on the Internet. So we can always do this, okay. But you know, on the Internet, you have everything in really fake news and unreliable. You have people that actually really take advantage of the distress of people. So we have some real sources which should be labeled by the states and the healthcare authority in France, with whom we've been working for a long time. Wait a minute, Madame. I'm going to finish, please. So the patient who actually belongs to the medical record is the patient. This is something new. Then you had to distribute this so that the patient could have access to medical records. So you had to actually insist on the doctors to write these medical records in a legible fashion, because you had references and you had different departments involved, and that made things more complicated. It was important to have a codification of the medical wording, so the medical record could be asked by the patient when he would be exiting from the hospital. We can do some statistics, but it was not always respected. But actually, sometimes it's done very smoothly. There are places, where you know very well, there are places where when you actually leave the hospital, this is when the patient is proposed to have the medical record. And then it's relatively legible. And so we ensure that it is legible for the patient. So this medical record. This explains and this underlines and leads to more responsibility for the patient, because once they have the medical record, if there is an appointment, then they can ask for explanations that should be provided to them. I agree. The individual, in a general situation, the patient, in fact, we're all going to be patients. The patient needs to be informed about their rights, about what he can ask for. In fact, the rights, so we're pushing for the fact that when, in fact, you're going to be consulting a surgeon, what is his rate of error for different post-operation situation? And is he experienced? Has he done 15 or 100 different surgery cases in a year? So, in fact, it's really because what is his level of competence for handling complications? These are important questions. So the different Express and Le Point magazines, that they give a list of the top hospitals, the most important ones. They give this listing, and they look at the acts, the different healthcare results. And what's interesting for us is that and I'm going to talk about something that concerns men, when you have the prostate cancer, for example, when you have surgery for this, it's better that the surgeon who does this can ensure that you can have a life of a man behind this. If the man does not ask questions, what will be the situation after the surgery, then he will have an impact on his private life. So it's very good. There are things that have started being done. It takes time, it's long, but in the political arena, it must be pushed. We need to have means so that we can co-develop with everyone. Yes. It's easy to say, but difficult to do. Yes, we have to really do everything we can. Now, yes, you have the responsibility of the patient and the doctors. All of this is related to information. When I was a minister, and even the previous term, we did actually work very much so that information in the medical area be actually covered by health insurance. Public health was not then, and medical information took a long time. We say, okay, in fact, you were at the Ministry of Health, and it takes time to make these things. So these medical information, we can talk about this. The health care was really the poor parent of the health care situation. What was public health care? Everything was concentrated on the diseases then. The disease or whatever the symptoms, etc. Everything was concentrated on this. Now, we cannot say that healthcare today is completely isolated. Public healthcare, which of course has information, lots of information, and I believe things are going better. But there's money for this. Within the health insurance, we're going to see what we're going to do with health insurance in these days. That's another question. But to continue, now, to finish, it was important to, in fact, we had lots of public sessions to really have essential questions and debates, which were very interesting. We did not completely really eliminate this idea that all this was the responsibility of the doctor, that was he that you have to trust. But of course that was being done. But that was not solely isolated his responsibility. But in fact, we looked at the relationship between patient and doctor in an ad hoc basis. There were a lot of difficulties with the surgeons and doctors who did not have a well-prepared the different secondary potential incidents. And when that happened, then they were actually criticized for not having evoked them. Now, our things went quite well, but there were a lot of different things that happened. Already, we looked at this problem. In fact, we spoke about this together, Guy, at the end of life issue. And me, and in fact, all of us at the end of life, is a sensitive problem with one point that I hope with these groups that are actually organized today, which will be meeting next week, in fact, on these questions. And specifically, we had a group with all the representatives of all the different religions, with some doctors, first of all, very competent ones with good reputations, and then we had these different professional unions also together. Things were really advancing very slowly. We did this for more than 1 year, and we did not achieve to have a final decision about what we should do. I observed, and I still see today, that for the end of life, in fact, this was even stronger. We were afraid at the hospital then that you would be, we would need some beds, and so that's why people would actually their end of life would be quickened. In fact, things were going that direction. We were afraid of that. And we were afraid that, above all, that it was obligatory. And also, we can say we don't have enough beds. We have so many patients. We have to free up beds. So we had this debate on the end of life. It's not obligatory. It's so simple. And nobody, if you don't want to be informed on that, because you also know you want to finish your life naturally, which is the customary. It's not. In fact, you don't have to go see someone to see how we can do this. Dear Bernard, unfortunately, we will have to stop. But in fact, we could spend the whole morning on this topic. But look at this. Look at this book. Just a point for you. you had Biafra. You had the Kosovo Ministries of Health, Ministry of Foreign Affairs, all your experience in Nobel Peace Prize for Médecins Sans Frontières that you co-founded Doctors Without Borders. We can applaud you, Bernard Kouchner, who passed his public life at the service of others. Thank you so much, Bernard Kouchner. That's why I didn't want to say anything simply. So thank you so much. I would like to say, very, very kind to really talk about this Peace Award, Nobel Peace Prize that we had. And Kosovo, 120, 130 countries recognized Kosovo. Now the first president is in prison. In The Hague, and at the penal court in The Hague. This is, well, in fact, we didn't have this institution before, but it's good we have it. Now, his court proceedings will take place in 3 or 4 years. So this guy, well, this is the situation it is. Now, if you have the opportunity of to inform that we need to accelerate these legal proceedings, that will be the next meeting. Thank you. Thank you so much.